Hello and welcome to Talking About Tumors with Ryan and Ryan. Just Ryan Holstead today and returning back after a long delay. For those of you who have continued to listen to our episodes, and especially to those of you who have provided ratings or reviews on the various listening apps, we greatly appreciate the ongoing support. We're going to continue to move forward into our last few discussions on malignancies that don't really fall into a nice disease site as some of the other ones that we've talked about in the past. And today I'll be discussing a very unique tumor type, the neuroendocrine tumor. This is a very broad disease and covers tumors that can arise from many locations. Most commonly, the disease site that we encounter in clinical practice arises from the midgut, such as the pancreas, stomach, or small bowel, or potentially from the lung. Neuroendocrine tumors can be found arising from many different organ sites, and hindgut, appendix, or colon are also not an uncommon site. Given the breadth of this topic, as well as a lot of minutiae on differences between individual disease sites, we'll try to take this from a view from 1,000 feet, while also honing in on some of the landmark clinical trials that have been guiding our practice as patient population. Some important differences to keep in mind depending on where a tumor arises is that some disease sites may be more prone to having more of aggressive presentation, such as the pancreatic neuroendocrine tumors or maybe an atypical lung carcinoid. And depending on the site of origin, there may or may not be more likely to have hormone secretion, such as the classic carcinoid syndrome or other secretory syndromes, which we'll get to shortly. First, just a note on nomenclature. The term carcinoid tumor is possibly falling out of favor, at least for many of these cancers. The word means cancer-like, and some have suggested that where these are truly cancers and they are malignant with various behaviors, they shouldn't be termed as cancer-like. As far as the GI origin of these tumors goes, the term carcinoid tumor has fallen somewhat from favor, and usually the proper term nowadays would be considered neuroendocrine tumor. Within the lung space, carcinoid tumor is still used, and these are typically broken down into a typical carcinoid or an atypical carcinoid. Neuroendocrine tumors exist on a spectrum. These can range from very well-differentiated indolent tumors whose rate of growth may not be detected even in scans that are more than a year apart. On the opposite end of the spectrum are the neuroendocrine carcinomas, and these are poorly differentiated tumors that behave not unlike small cell lung cancer, although can be even less chemotherapy sensitive. Because of their behavior, the neuroendocrine carcinomas, which are typically high grade, grade 3, or with a high measurement of proliferation, which is estimated through Ki-67, the approach to these is often extrapolated from our small cell literature. So we'll be outside of today's scope, but in general, these patients are often offered carboplatin and etoposide, with some nuances depending on where the tumor arose from. The more well-differentiated a tumor is, as well as the more indolent nature it is, the less likely it's to be responsive to chemotherapy. And we'll see when we talk about the clinical trials, we really don't see high response rates in the well-differentiated or even in the intermediate grade tumors. More often than not, we just see a slowing of progression or maybe stabilization of disease. This has led to difficulties in designing adequate trial designs to quickly get to an answer of determining whether or not a novel therapy is going to be effective in an individual disease site. Furthermore complicating this is the relatively long survivals in these patients with well-differentiated tumors of the midgut or small bowel, often having prognoses that last 5 years or longer. Given the rarity of the tumor, long prognosis, this has limited the rapid development of high-quality clinical trials. However, over the past couple decades, we've been able to accumulate some critical understandings on the management of these tumors. One thing also to keep in mind, this is a cancer that often is found in the metastatic setting, and when a metastatic tumor does have a prognosis that is measured in years, such as 5 years or longer, it's important to be mindful of the psychological impact that this can have on someone. Patients don't think twice about having hypertension and living for years with this. However, having a capital C cancer and living for years can have long-term impacts. It is important to be mindful if you're managing these patients of mental health, addiction, and anxiety. In North America, the guidelines that direct our approach to these cancers are under the North American Neuroendocrine Tumor Society, or NEJM. Europe has an equivalent society called ENETS, and ESMO also produces great guideline documentation on this disease. When I'm trying to brush up on one of these tumors, I typically look at NEJM, ENETS, and ESMO and try to find the most contemporary guideline statement. ESMO in particular publishes some excellent diagrams that summarize treatment algorithms, which can be very helpful, especially if you're learning or seeing this disease for the first time. Given the number of things we're going to hopefully accomplish through today. I won't be spending too much time on localized tumors. We'll focus primarily on the metastatic disease. Often when localized, these tumors can be resected and don't warrant adjuvant therapy given their chemoinsensitivity as mentioned above. It's important that if you are in a site where medical oncology typically follows these patients in surveillance, to be aware of the indolent nature does mean that follow-up needs to extend up to about 10 years. So unlike colon cancer, we typically think of the highest risk of recurrence being in the first 3 years, rarely seeing recurrence beyond 5 years. These are tumors that have a relatively linear recurrence rate, and the further you get out, you're just as likely to see disease recur from year 1 to 2 as you would from year 8 to 9. Because surveillance will be extending up to 10 years, it's also worth being mindful of radiation exposure and not overscanning these patients. So often an approach of either doing scans once a year or alternating between CTs and MRIs to limit radiation exposures. Not all neuroendocrine tumors are hormone secreting. It's important, though, to rule these out at the time of initial presentation. Some of the classic carcinoid symptoms are bronchospasm, flushing, sweats, all of these which are relatively nonspecific symptoms and may be present for years or may be accumulating in frequency as it comes to the presence of the disease. Usually when these symptoms are related to the carcinoid tumor, they're near daily. The sites of origin that are most likely to demonstrate carcinoid syndrome are from the pancreas, small bowel, and lung. You're unlikely to see carcinoid syndrome from localized tumors and more likely to see it in metastatic disease. The severity of symptoms do seem to correlate with the extent of disease. Right heart valvular disease is certainly something to be mindful of. This is unlikely to be seen in patients without symptoms of secretory syndrome, but if someone is having carcinoid-like symptoms such as flushing or diarrhea, you should consider doing an echocardiogram with specific focus on the right heart valves. As a result of the circulating hormones, there ends up being deposition on the right heart valve. This can lead to heart failure, and with enough time or left untreated, often this will then progress into left heart disease as well. If you are suspicious for carcinoid syndrome, the preferred test would be a 24-hour urinary 5-HIAA. Although this test is fairly sensitive and specific, it's important to be aware of interactions with many common foods, such as avocados, pineapple, banana, eggplant, and tomatoes, also along with the interactions with medications such as Tylenol, caffeine, and nicotine. Patients should abstain from these over the time of doing the testing because false positives can arise. There are great references available online giving a list of all the medications and foods to be mindful of. There are blood-based testing for carcinoid hormone secretion, such as plasma serotonin levels. However, these are not overly standardized and not the most reliable. Chromogranin A is another blood-based assay, which can correlate with response to disease, however, it does not seem to correlate with carcinoid symptoms. Beyond the carcinoid syndrome, other secretory syndromes, such as especially with gastric or duodenal neuroendocrine tumors, include the Zollinger-Ellison syndrome, which is gastrinomas. In Zollinger-Ellison syndrome, patients have increased gastric acid, so peptic ulcers disease, severe diarrhea are not uncommon findings. This associates with MEN1 syndrome. However, approximately 75% of patients with this syndrome are negative for MEN1. Other non-carcinoid secretory syndromes include VIPomas, glucogenomas, and ACTH secretory syndrome. This may be seen in pancreatic or duodenal tumors most commonly. If you're suspicious or have a biopsy demonstrating neuroendocrine tumor, diagnostic workup should include somatostatin-based imaging. This would be in addition to staging CT chest, abdomen, pelvis, or an abdominal MRI. The purpose of a somatostatin imaging is twofold. One, to improve staging by identifying lesions that are expressing somatostatin on surface, as well as predictive to respond to therapies that we're going to discuss shortly that act upon these receptors. In North America, the traditional octreotide scan is falling out of favor as PET-based therapy has shown increased sensitivity at detecting disease. There's multiple different PET modalities, such as dotatate or copper. These are different than FDG PET scans, and it's important to know the difference, as indolent tumors tend to be relatively cold or not show up well on FDG PET, but may show up very well on a dotatate PET. The neuroendocrine carcinomas, or more aggressive behaving tumors, tend to lose their somatostatin receptors, and in these more aggressive behaving tumors, a FDG PET may be your preferred test, and for some tumors that may straddle kind of the intermediate range, if you're able to access this, performing both an FTD and a dotatate PET may be beneficial to characterize your tumor's behavior. Pathologic analysis of these tumors typically demonstrate uniform cells, unless it's a high grade. The immunohistochemistry will often demonstrate chromogranin, and somatostatin, also which can be seen in small cell lung cancer. These tumors should be evaluated by a pathologist who's familiar with the disease and should be provided a grade, which is based upon the WHO criteria, the differentiation, which can be called well, intermediate, or poorly differentiated, and a measurement of proliferation rate should be provided, which may be estimated with total mitoses per high-powered field or by Ki-67. High-grade tumors will have a Ki-67 of greater than 20% or a mitotic rate of greater than 20 per high-powered field. The lowest grade tumors or in well-differentiated grade 1 tumors would have a mitotic rate of less than 2 and a Ki-67 of less than 3%. Moving along into management of these tumors, once again, as mentioned before, if it's a localized disease, surgical resection is usually going to be your initial approach. Sometimes if this is seen in an older or frailer patient, or possibly if the primary tumor is in an area where surgical resection could have high mortality, such as within the pancreas, which may warrant a Whipple surgery. Initial monitoring may be considered. As mentioned before, these tumors may have a long period of time before progression is noted, and sometimes can be watched for a few years prior to surgery being necessary. And in elderly or frail patients may never actually warrant a surgical resection. If the disease is metastatic, it's important to initially evaluate this with a multidisciplinary evaluation. This is one tumor, especially in the well-differentiated or less aggressive behaving, where a debulking surgery may be considered. This is one of the tumors where debulking surgery does have long-term improvements in patients' quality of life and survival. Other tumors where debulking in a palliative but with long-term benefit setting would also include ovarian cancer or glioblastoma multiforme. Often the management approach to these patients would include consideration of surgery or local regional therapy, especially for metastatic hepatic deposits, where ablation or embolization may be able to provide local control. For patients who are incompletely debulked or have tumors that are not amenable to surgical resection, the approach depends upon the primary site of disease as well as the tumor behavior. You can estimate how this tumor is going to behave based upon its degree of somatostatin expression, mitotic rate, and grading. Metastatic well-differentiated disease, as with local disease, may be amenable to an initial period of monitoring without systemic therapy. However, if it does begin to show evidence of progression, we often like to initiate systemic therapy once the disease is clearly in an active state and prone to growing. As mentioned before, systemic therapy does not cause a high response, so the goal is really to slow the rate of growth in order to prolong the time between growth and developing complications of the disease. As many of the well-differentiated tumors express somatostatin, our initial approach to systemic therapy is often treatments that target this receptor. We have two somatostatin analogs that are FDA approved, octreotide and lanreotide. Octreotide comes in a short-acting formulation, which is given as a sub-Q injection 3 times a day. The short-acting, it can be a good way of initially treating for carcinoid syndrome, but it's not a convenient way for obtaining long-term disease control. Octreotide is also available as a depot formulation, which can be injected once per month. Lanreotide also comes in as a depot injection that is once per month. Once a patient is stable on long-acting formulations, you can likely control their carcinoid symptoms well enough and not need to continue a short-acting octreotide. Would be relatively rare to need to use the short-acting octreotide nowadays. However, in patients with a true carcinoid crisis or developing significant cardiac concerns, you may want to rapidly reduce their hormone secretion. Octreotide was the earliest approved for management of this disease and is usually dosed at 30 milligrams once a month. However, the depot can sometimes be used up to 60 milligrams, which is an off-label escalation of therapy with the goal of treating for once the tumor started to progress. Its benefit was first shown in the PROMID trial, which was a randomized controlled trial that included patients with pancreas and small bowel neuroendocrine tumors, all with an excellent functional status and with well-differentiated or intermediate grade tumors that express somatostatin. These patients were randomized 1-to-1 to receive octreotide 30 milligrams once a month or placebo. The primary endpoint was time to progression. This had an alpha of 5% to detect a hazard ratio of 0.6 with 80% power. The study met its primary endpoint, and the time to progression with octreotide was 14 months versus 6 months with placebo. 66 of the patients on octreotide continued to have evidence of stable disease at 6 months. This benefit was shown regardless of whether patients had a functioning tumor. The follow-up study did show relatively similar survival between arms. However, the majority of patients on the placebo arm did have crossover. Toxicities in this study were shown to include cholestasis. It's worth noting that some centers that are expecting to give octreotide at the time of debulking surgery may consider doing a prophylactic cholecystectomy. Other toxicities from octreotide include hyperglycemia. It's worth noting that this can be sometimes severe, so it's important if you're managing these patients to be mindful of their glucose and ensure someone is following their hemoglobin A1C. Other complications include hypertension, abdominal cramping, diarrhea, flatulence, fatigue. There are reports of arrhythmias. However, this is more typically seen when we're giving high-dose octreotide in an IV formula, not often used in the day-to-day practice of these patients. Lanreotide is a nearly identical medication, has a similar mechanism of action, and has some additional nuances that make it potentially less convenient to octreotide, namely that it has to stay cold and must be removed from the fridge about 15 to 30 minutes prior to the injection. This can cause a logistical challenge as patients, because once this drug has been warmed to room temperature, it must be used or disposed of, so most centers won't be able to take it from the fridge until the patient's in the room, and that means that the patient would then have to wait 15 to 30 minutes before getting their injection. The landmark study for lanreotide was the Clarinet trial, and this had similar inclusion criteria to the PROMATE trial, however also included patients with hindgut tumors that were expressing somatostatin. The study was also placebo-controlled, randomizing 1-to-1 with lanreotide at the standard dose of 120 milligrams versus placebo. Progression-free survival was significantly improved, with the median not reached in the initial publication versus 18 months of placebo. Toxicities appeared quite similar to octreotide, and to my knowledge, these two have never been studied in a head-to-head format. So depending on where you work, you may see octreotide or lanreotide in more common use. Over the past 10 years, we've been fortunate to receive additional therapies that act upon the somatostatin receptors. The best study to this is 177 lutetium dotatate. Brand name of this is Lutathera. And it's very similar to our PSMA radiolabeled therapy that we discussed back in our prostate cancer era. You may hear this as PRRT, which stands for Peptide Receptor Radionucleotide Therapy. The landmark study for the 177 lutetium dotatate was the NETTER-1 trial, and this was published in 2017 in the New England Journal. This took patients who were previously on a somatostatin analog, either octreotide or lanreotide, with well-differentiated midgut tumors. They randomized these patients 1-to-1 to either receive octreotide 60 milligrams once a month, or the intervention, which was receiving the lutetium dotatate every 8 weeks for 4 infusions. Prior to each infusion, the patients did receive a 30 milligram injection of octreotide. The primary endpoint of the study was progression-free survival. They had designed the study to have 80% power and had an alpha of 5%. They initially planned to enroll 124 patients, but it expanded upon their enrollment to assess specifically for overall survival after an amendment. At 20 months, progression-free survival was 65% in the lutetium arm versus 10% in the continuation of somatostatin analog arm. Median overall survival was numerically improved, but did not meet statistical significance, with MOS being 48 versus 36 months. Toxicities of lutetium dotatate included nausea, vomiting, fatigue. There's a risk of myelosuppression, although this was generally mild, and renal toxicity, which is also relatively mild. 2% of the patients developed MDS in the intervention arm. We generally think of lutetium dotatate as being a one-time shot because when used in a second course, these toxicities can be a lot more profound, namely with the myelosuppression and renal toxicity. This therapy does actually have a reasonably high response rate for well-differentiated tumors at 17%, which is higher than what we've seen in our other hormone-based therapy. So I think the approach to this should be, considering the timing. It's an effective therapy, but if we can only use it once, we want to use it when we need it most. And that's usually when we've exhausted local regional options and have gotten to the point where we're concerned continuing just a somatostatin analog might put the patient at risk for a complication due to regional progression. More recently, a NETTER-2 trial published, and this looked at using lutetium dotatate in the first-line setting. The study also included patients with grade 2 or intermediate grade disease. It showed improvements in progression-free survival compared to a somatostatin analog, which is not necessarily a surprise. And it didn't answer the question of whether or not we need to use the drug sooner. I would not say that using lutetium dotatate in the first-line setting has necessarily become standard practice, but you may consider if you have a patient with relatively high burden of disease, demonstrating relatively rapid growth, and where you worry that you need some better control than just a somatostatin analog alone. If a patient doesn't express somatostatin on their PET scan or octreotide scan, there is no role for lanreotide, octreotide, or lutetium dotatate. In these patients, you may be able to offer other systemic therapies. However, the degree of benefit may be variable. Usually tumors that are somatostatin receptor negative are more likely to be grade 2 or greater, and more aggressive tumors do tend to respond a bit better to chemotherapy. The exact protocol to which systemic therapy for non-hormone sensitive tumors depends on the site of origin, and we will try to go over briefly some of the major treatment options for these. So starting off with pancreatic neuroendocrine tumors, these are a bit more chemosensitive and a bit more therapy sensitive than some of the other disease sites. And in fact, they've had some good evidence showing that alkylating chemotherapy can cause a response. Temozolomide, which we're going to talk about in much more detail in our glioblastoma discussion, is a chemotherapy that we haven't spoken about before. Briefly, this is a chemotherapy that induces methylation at the O6 position of guanine. By sticking methyl groups on guanine, this destabilizes DNA, causing cell death. There is a protein, MGMT, that removes these methylated proteins, helping to preserve DNA. So when patients have cancers that have a mutation in MGMT that leads to a lack of secretion of this protein, they are unable to correct these methylated guanines and are more likely to be sensitive to temozolomide. So MGMT activity is meaningful in the glioblastoma space. However, using this as a marker response has not fallen into pancreas neuroendocrine tumor standard practice. A landmark trial for pancreatic neuroendocrine tumors that has guided our chemotherapy management was actually a phase 2 trial. This was the E2211 trial, and this included just patients with pancreatic neuroendocrine tumors with low or intermediate grade. These tumors had to have some degree of progression on observation or a previous TKI, lanreotide, or everolimus. Somatostatin analogs were allowed during the course of this trial if a patient expressed somatostatin receptors. In this study, patients were randomized 1-to-1 to either temozolomide alone, given as 200 milligrams per meter squared for days 1 through day 5. This is an oral agent, and this was given every 28 days. The intervention arm used capecitabine, which was given as 750 milligrams per meter squared. So a relatively low dose of capecitabine. If you remember, our usual doses are in the 1,000 or 1,250 milligrams per meter squared. So in the study, they used 750 milligrams per meter squared on days 1 through 14, and temozolomide was given at the tail end of those 14 days. So on days 10 to 14, the patients received 200 milligrams per meter squared of temozolomide, and this was also repeated every 28 days. Primary endpoint for the study was progression-free survival, and just under half, at 40%, were receiving a somatostatin analog. This showed an improvement in progression-free survival using capecitabine and temozolomide of 22 versus 14 months. And this had a hazard ratio of 0.6 and was statistically significant. Response rates were not too different between arms at 40% versus 34%, and benefit was shown in both the low and intermediate grade tumors. There was a trend towards overall survival. However, this was a relatively small study with 72 people in either arm, and it was unable to show statistical significance. The combination of two chemotherapies did increase rates of myelosuppression, and temozolomide is notorious for thrombocytopenia. There's also hand-foot syndrome seen in the intervention arm as a result of capecitabine. So in patients with pancreatic neuroendocrine tumors for whom progression has happened on your somatostatin analog and the patient is fit, capecitabine temozolomide is certainly a reasonable option. In a less fit patient, you may also be able to consider temozolomide alone. The findings of the study have been extrapolated to some other disease sites, such as small bowel tumors, especially in grade 2, relatively more rapidly growing tumors. In pancreas or small bowel tumors that either have progressed on capecitabine or temozolomide, or if patients are not candidates for chemotherapy, other agents that have been studied include sunitinib, everolimus, and cabozantinib. All of these drugs have relatively high toxicities. We've covered them at length at prior discussions around hepatocellular carcinoma and renal cell carcinoma, but just as a reminder, these can cause mucositis fatigue, hyperglycemia, hyperlipidemia. In all cases, these treatments tend to cause stabilization and delay progression rather than a true response. For pancreatic neuroendocrine tumors that are grade 3, our preferred approach will depend upon the degree of Ki-67, with those with the Ki-67 less than 50% being offered capecitabine and temozolomide. However, if the tumors are poorly differentiated or what would be called a neuroendocrine carcinoma, or if the Ki-67 is greater than 50%, then you're going to be offering a platinum and etoposide doublet. Once again, extrapolating from small cell literature. There's no evidence for immune checkpoint inhibitors in this disease site, and due to the rarity of it, it's unlikely there'll be a randomized controlled trial incorporating immune checkpoint inhibitors. In terms of carcinoid tumors that arise in the lung, typical carcinoids are tumors that are going to have a low mitotic count of less than 2 per high power field and should not have any evidence of necrosis on the biopsy. Atypical lung carcinoids tend to be a bit more aggressive and these typically have about 2 or greater mitoses on a high power field, and usually will have some evidence of necrosis on the biopsy. If a lung carcinoid, whether it's typical or atypical, is localized, your initial preference would be surgery. Metastatic disease, if it's expressing somatostatin receptors, you can consider offering a somatostatin analog. Often atypical carcinoids don't have as much expression, and these are treated similar to pancreas neuroendocrine tumors with either everolimus or temozolomide capecitabine as our initial approach. Lung carcinoids are not very sensitive to chemotherapy, and there's not strong evidence for adjuvant chemotherapy should one of these tumors be surgically resected. So that summarizes our systemic therapy options for the most common sites, both in the pancreas, small bowel, and lung. It's important, once again, that we look at neuroendocrine tumors in a multidisciplinary fashion, and if available, at a center of excellence where providers are familiar with these diseases and their unique behavior. These are often slow-growing tumors, so it's important to take time, get an understanding of how each individual person's disease is behaving and where the significant burden of disease is so that you can anticipate potential complications. It's important to make sure that you know whether or not these patients have hormone secretory tumors and tumors that do secrete hormones, to be mindful of some potentially devastating complications such as carcinoid heart syndrome. When appraising evidence on the approach to these diseases, keep in mind their long prognosis, limited response rates to therapy, and relative rarity will mean that we have to use endpoints other than overall survival to help formulate our treatment decisions. I hope this was a helpful introduction to this tumor type. And for those of you who've been continuing to follow along, we greatly appreciate all the attention. We greatly appreciate to those of you who have not left a rating or review to do so on whatever app you tend to listen to this discussions on. We'll be hopefully back very soon to complete our major tumor site discussions with glioblastoma multiforme, and then plan to do a series of interviews with some of our allied specialists like radiation oncologists, surgical oncologists, and clinical pharmacists to get an idea to introduce their role in multidisciplinary medical oncology care. Thanks again for listening. Bye for now.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.